Thank you so much for joining us for Cardiac Conversations, Fetal Diagnosis and Intervention for Hypoplastic Left Heart Syndrome. I am Christina Ronay. I'm one of the fetal cardiologists here at Boston Children's Hospital, and I have some fabulous panelists joining me. Wayne, would you like to go next?
Hi, everyone out there. My name is Wayne Turetsky, also a cardiologist at Boston Children's Hospital and the director of the fetal cardiology program.
Tara?
Hello, my name is Tara LaFranchi, and I'm the fetal cardiology coordinator and nurse practitioner here at Boston Children's Hospital.
Erica?
Hi, I'm Erica. I'm one of the physician assistants here at Boston Children's Hospital. I work on the cardiac surgery team, both in our cardiac ICU and OR.
And David?
David Hoganson. I'm one of the pediatric cardiac surgeons, and I'm involved with taking care of the patients as part of the fetal consult team, as well as one of the neonatal cardiac surgeons.
Excellent. I will get us started. So very briefly, I was going to talk about what hypoplastic left heart syndrome is. I think a number of you have probably seen this diagram during some fetal counseling, but essentially you have an underdevelopment of the left ventricle. So you have a very small mitral valve, a very small left ventricle, a very small or maybe even atretic aortic valve into an ascending aorta. And the right side of the heart is usually formed with a good-sized right ventricle, a good-sized tricuspid valve, and pulmonary artery. Often on fetal echo, you can see this is what a fetal echo often looks like in terms of essentially all you're seeing here is a right ventricle, and the left ventricle is very diminutive on this side. So as we talked about it, it's usually an underdeveloped left ventricle with a hypoplastic or atretic left-sided valve, hypoplastic aortic arch and narrowing, which is another word for coarctation. And there needs to be a connection maintained between the aorta and pulmonary arteries, which is this ductus arteriosus right here. And you need a communication to be open between the top two chambers, which is a foramen ovale right here. The important things to know is that for hypoplastic left heart syndrome, often the fetus is very healthy while in utero. Fetal hydropsin demise is rare unless there's significant right ventricular dysfunction or tricuspid valve regurgitation. However, if the ductus closes after birth, there would be, unfortunately, 100% mortality. And then, as many of you know, and we will go into further, there is palliative surgery involving 3-stage procedures, usually done before 5 years of age. Importantly, some outcomes are worse for higher risk populations, especially those that have extracardiac anomalies, genetic or chromosomal anomalies, prematurity, less than 34 weeks gestational age. If the atrial septum, that communication I was showing earlier, is intact or restrictive, or as we mentioned, there was valve regurgitation or right ventricular dysfunction. The other important thing is that we see a lot of here at Boston Children's are what we would call borderline left hearts. And so here, all the way on this side, you can see there's essentially no left ventricular cavity, but it really is a spectrum. And so you can see here, you have a much larger left ventricular cavity, but it doesn't quite meet the apex of the heart. And then all the way over here where you have very mild hypoplasia with a near normal left ventricle. This is a nice fetal example of, you can see that this left ventricle is almost meeting the apex. And a lot of times in our borderline left heart patients, we see that they have an abnormal mitral valve. And so sometimes it can be parachute, sometimes there can be a membrane. And a lot of times the aortic valve can either be small with subaortic stenosis or coarctation of the aorta. For these patients, they often don't need those palliative procedures. And a lot of times we can see how they do with just an aortic arch augmentation and repair of the coarctation. So as I mentioned, it can be a very heterogeneous group with obstruction below above or at the mitral valve. And similarly, there can be narrowing below the aortic valve, at the aortic valve, or above. And sometimes this gets referred to as Schoen's complex. And that was where I was going to stop and pass it off to Tara.
One moment, I'll be right with you. Can everyone see my slides?
Yes.
Great. Thank you for logging on tonight. If you have just learned that your baby has HLHS and you will be referred to BCH for a fetal echo and consultation, I will now provide you with a brief overview of what to expect. Your visit will begin with a fetal echocardiogram, which is essentially an ultrasound to take detailed pictures of your baby's heart. When the test is complete, we will bring you to a private meeting room to have a consult with your fetal cardiologist and other team members. Your consult will begin with an illustration of the normal heart anatomy and then of your baby's specific heart problem. The prognosis, surgical options, and outcomes will be presented to you. Most importantly, we want you to know that you did not cause this to happen. It's nothing that you did or didn't do. We know how hard this is for you learning that your baby has HLHS, and our approach is to be both compassionate and honest. When you are carrying a baby with HLHS, we recommend that you transfer care to an MFM or a high-risk OB. One of your first parenting decisions will be to decide where you will deliver your baby. For best neonatal outcomes, your delivery should occur at a hospital adjacent to the neonatal cardiac surgical program of your choice. This will allow for a smooth and timely transfer of your baby, as well as ease of parent and baby visits. The ideal timing for delivery is in your 39th week of pregnancy, so that your baby is a good size and their brain and lungs are more developed. If you're traveling from a distance, we recommend relocating to Boston in your 36th week of pregnancy so that you're close by if you go into labor early, because we all know babies don't always follow our plans. The type of delivery is typically a decision you will make with your MFM, but vaginal delivery is preferred when possible. An induction or C-section will likely be scheduled during your 39th week of pregnancy. The MFM team does not usually allow for delivery after 40 weeks because the placenta gets tired for babies with congenital heart disease. This delivery plan may change if your baby has high-risk HLHS or if there are other maternal or fetal health concerns. When your delivery day has finally arrived, we know you will be nervous, but we want you to know that we are ready and expecting your baby to come out and cry and look good and be stable. Although babies with HLHS are often referred to as blue babies because they have cyanotic heart disease, we do not expect your baby to actually look blue or require emergency resuscitation in the delivery room. The NICU team or the baby ICU team will be in your delivery room, and the cardiology team will be on standby in case your baby needs any extra support. When your baby is born, the NICU team will start an IV to start prostaglandins. This is a medication to keep the ductus arteriosus open after birth, which will help keep your baby stable while waiting for surgery. You will have time to say hello to your baby before they are brought to our cardiac ICU. Your spouse or partner can accompany your baby to the ICU, and depending on how you're feeling, we hope you will be able to come see your baby within a few hours. When you're able to visit, we are hoping that your baby will be stable and you will be able to hold your baby, have skin-to-skin time, and start breastfeeding if you'd like during those first few days before surgery. It is helpful to tour the CICU virtually or in person prior to delivery so that you know where your baby will be cared for. The first surgery for HLHS will take place in the first week of life. You should be prepared for lengthy hospitalization, approximately 1 to 2 months from birth to discharge. During your pregnancy, you will be scheduled to meet with our neonatal cardiac surgery team to learn more about innovative surgical options at Boston Children's for HLHS. During your fetal consult, we will also include information pertaining to care beyond your baby's first surgery. Neurodevelopmental concerns are discussed, along with our proactive strategies for early detection and treatment. Our cardiac neurodevelopmental team cares for families prenatally, after birth, and throughout childhood. Families are scheduled to meet with our CNP team while they are pregnant because, believe it or not, there are actually things you can do during your pregnancy and right after birth to help promote your baby's development. We will provide you with information about growth and nutrition and what the standard feeding protocol is for HLHS babies. They are at higher risk for feeding-related issues, and many families report this can become their greatest stressor following surgery. Fortunately, we have many amazing specialists to help with any feeding challenges that may arise. If you are planning to breastfeed before learning about your baby's heart condition, this is still possible. Every family is offered a prenatal lactation consult, which can be helpful whether you plan to breastfeed, pump, or provide hospital-supplied donor milk to your baby. In addition to learning about the need for lifelong medical care and the risk of potential complications, we know that you may also be interested in whether or not your child will grow up to reach other milestones, like going to kindergarten, learning to ride their bike, playing in a golf championship, graduating from high school, or having their own baby one day. Regardless of where you receive care, learning your unborn baby has a serious heart condition is stressful and you will need support. We tell families like you to prepare for a marathon, not a sprint, and that you will experience uncertainty, not only during the remainder of your pregnancy, but throughout your child's 3 surgeries and beyond. Our team, including social workers, will help you address the social and emotional challenges you are facing. Another important component of prenatal counseling is providing standardized educational materials for families. Creating these materials has been a passion of mine because this is one way to decrease the discrepancy between what families are told and what they hear and what they can actually remember during a very stressful time. These materials can also decrease anxiety for families by arming them with additional knowledge and resources to read at home, possibly in the middle of the night if they're lying awake worrying. A fetal cardiology visit summary is also provided as part of your consultation. To help families prepare for the road ahead, we published a 60-page guide. If you would like to download a free digital copy, the link will be in the chat. My goal is for any family expecting a baby with HLHS to have access to this valuable information, regardless of where you live or where you will deliver. And like I tell all of the families I care for, please reach out if you have any questions. I do not want you to worry at home alone. And lastly, thank you to all of the HLHS families that I have cared for throughout the years. Caring for you has truly been an honor, and you have directly improved care for all of the families that have followed you. Thank you.
Thank you so much, Tara. While Wayne's getting set up, just for everyone to know, there's a bunch of links that we put in the chat, including the fabulous HLHS guide, travel and housing information, lactation support, neurodevelopmental, and the virtual tour of the cardiac ICU.
Okay. You see my screen?
Yes.
Okay. Hello to everyone out there. I see some names of people I know out there. So hello to friends, colleagues, and some patients. And so what I'm going to talk about is a particular subgroup of hypoplastic left heart syndrome. There are some patients that are amenable to fetal therapy for hypoplastic left heart syndrome, and I will focus mostly on that. So there are different types of heart defects that are amenable to in utero therapy, and these are needle and catheter-based therapy over here, and there's also medications that we give to the mother that then gets through to the fetus. In terms of the needle and catheter-based treatment, balloon dilation of the aortic valve in patients who have developing hypoplastic left heart before it's progressed to that point, and that's what I'm going to focus mostly on. There's also placing stents in the atrial septum in those that have hypoplastic left heart with intact atrial septum. That's a very serious form. Also balloon dilation of the pulmonary valve in pulmonary atresia or hypoplastic right heart syndrome, and then medications to the mother and fetus to treat arrhythmias or rapid heartbeats, sometimes steroids and IVIG for slow heartbeats, and also non-steroidals such as ibuprofen in select patients. But I'm going to really focus on needle and catheter-based therapy for aortic valve balloon dilation to prevent progression to hypoplastic left heart in a select group of patients. So some versions of hypoplastic left heart, and there are many different versions of hypoplastic left heart, start out where there's a blocked aortic valve and the left ventricle is enlarged or dilated. And if you leave these alone, eventually what happens is that the ventricle shrinks. So this would be at 23 weeks. When you get to late gestation, the ventricle has become small like this. And that's one version of hypoplastic left heart, where predominantly the aortic valve or the outflow valve from the left ventricle is blocked to the point where the left ventricle becomes damaged. Now, I'll show you an example of a patient that was a good candidate for this fetal therapy and had a good outcome. And these are the ideal types of patients. So here we see a patient that was first seen at 22 weeks at another institution. And they called us and said, what do you think of this? And I said, well, at this point, you can see there is mild aortic stenosis. You can see this disturbed flow across the aortic valve here. But at this point, the four-chamber view, and those of you that have had a fetal echo know they show you the four chambers, and you can see that this still looks pretty normal. And you can see that the heart is squeezing well, and there's good blood flow around the aortic arch. And that's what we like to see in a normal fetus, is forward flow around the aorta, or the main blood vessel that goes to the body. But what happens in some of these patients, if you follow them very closely, and we always recommend, if there is even mild aortic stenosis, we recommend them being followed weekly. At 25 weeks, so within 3 weeks, the ventricle became severely dysfunctional. So you can see it's enlarged, the left ventricle, and also it's not squeezing very well. And in comparison over here, you can see 3 weeks prior, the ventricle was still squeezing well. So this was progression of the aortic stenosis, or the narrowing in the valve, and that affected the way the left heart was squeezing. And this is the type of patient that we're sort of watching in real time developing hypoplastic left heart syndrome. And so if we can intervene in a timely fashion, we can help these babies. And here you can see the blood, the red flow is now flowing backwards in the aorta, and that's a sign usually that the flow is, that the heart is developing hypoplastic left heart. And so in a select group of patients, and again, I want to reiterate, this does not apply to all patients with hypoplastic left heart, but just those with predominant aortic stenosis. And these are procedures done under ultrasound guidance with my pediatric cardiology colleagues in ultrasound and interventional cath, and with the maternal fetal medicine ultrasound and the maternal fetal medicine team. And these procedures are done all under ultrasound guidance with the baby in utero using a small needle. And the needle is actually inserted straight into the left ventricle, and then a wire and a balloon is placed across the valve to open the valve. And I'll show you a little bit more of that. So again, this just in a cartoon format. The baby has to be facing upwards. The needle is placed into the left ventricle. And then what we do is we place a needle through the ribs, through the left ventricle, aimed at the valve. And then a wire and a balloon is placed across the valve. So this is what it looks like in cartoon format. And I'll show you the ultrasound, what that looks like. So here, this is the dilated ventricle in this patient. You can see the needle causing a reflection here. You can see the needle is placed into the left ventricle. Again, this is what it looks like in cartoon format. And then next, you can see this bright structure is the wire being advanced, the guide wire that guides the balloon across the valve. And then the balloon is inflated. So you can see this blush inside the red oval here. You can see as the balloon is inflated to open up the valve. And then we take all the equipment out. And you can see now how a week later, the ventricle now has improved its function. It's no longer very enlarged, and you can see what it looked like before the procedure here. And then what we see now is a nice broad jet of flow across the valve, and the flow is now again going forward around the aortic arch. So this is a good outcome from this procedure. And then when we looked in late gestation, so the procedure was at 25 weeks. This is now at about 38 weeks. You can see that the left ventricle is no longer very enlarged and dysfunctional and actually squeezing well. You can see this is the left ventricle squeezing well. And then you can see that the flow across the atrial septum is improved. And most importantly, the flow across the aortic valve is improved over here. And so we're very encouraged by the way this looked. And when this baby was born, the baby had what looked like an almost normal 4-chamber view. You can see a little bit of remaining scar tissue here from the original damage to the heart. And you can see again in this short axis view how the heart is squeezing very well. And there is a nice jet of flow across the valve over here. And this baby still had some residual aortic stenosis, but clearly a 4-chamber view and did not have hypoplastic left heart. And this baby did require another balloon dilation at a few weeks of age. But this example that I'm showing you, and of course I'm showing you a good example, not all of them end up this way, is what we'd call a jackpot success, meaning the baby was headed to hypoplastic left heart, the procedure went well, and we had the desired outcome. So this, we have many patients like this, but unfortunately not all do end up like this. And so we continue to learn about the procedure, about patient selection, and obviously to always do better for our patients. Many of these patients will ultimately require surgery, and Dr. Hoganson will probably pick up on some of the surgical procedures. So thank you for listening, and we look forward to helping our patients. Thank you.
Thank you, Wayne.
Thank you. I'll be focusing on our involvement in fetal surgical second opinions. Families reach out for a second opinion after learning their baby has a cardiac diagnosis, such as HLHS. When families reach out for a fetal surgical second opinion, our surgical team connects with families within a week of their inquiry. We gather imaging and collaborate with our cardiology team to review and confirm the diagnosis. Once the diagnosis has been confirmed, we schedule a virtual surgical consult to discuss the spectrum of the diagnosis and the potential options for palliation and surgical repair after delivery. Families get to meet directly with a cardiac surgeon to go over the details of the surgery, the postoperative course, and the timeline of subsequent surgeries. Many families reach out to us from across the nation, and we recognize that it can be daunting to consider relocating to another state while expecting the birth of their baby. We collaborate with the fetal care team to provide support and to help families to navigate this process, whether that means delivering in Boston or delivering locally and relocating to Boston after delivery for surgical intervention. We also provide support for families that are looking for guidance and reassurance that their local team is taking an approach that's consistent with our approach, even if they don't have the intention of relocating to Boston. Our mission is truly to provide a concierge level of care to families. Our program is unique in that throughout the second opinion and consultation process, families have the opportunity to meet and develop a relationship with providers that will be directly caring for their baby after birth. We maintain this close relationship while the baby is inpatient and collaborate with patients' local teams to ensure continuity of care after the baby is discharged from the hospital. I'll pass it along to Dr. Hoganson for more surgical details.
Share my screen here. So Dr. Hoganson, again, one of the pediatric cardiac surgeons, and cared for a lot of the neonates with single ventricle heart disease, including hypoplastic left heart syndrome. Just showing on my screen a three-dimensional model of a patient with hypoplastic left heart syndrome. You know, I think it's a real privilege to meet with these families before surgery and talk about some of the different surgical options that exist to treat hypoplastic left heart syndrome and other heart disease that requires surgery in the first week or two of life. And so I think a key aspect of that fetal visit is just to talk about the different options that may exist. Certainly the fetal echoes are wonderful, but we always learn more about the baby after the baby's born and the first echoes in the newborn period. And that really gives us the information to make the final decision about what surgical option might be best for these patients. And so, but it also gives an opportunity to talk about some of the details of the different surgical options and the expected outcomes, which Tara really nicely highlighted of the sort of expected lengths of stay in the ICU and in the hospital after these surgical repairs. So, so similar to what Dr. Rowe and I showed, this is a patient with hypoplastic left heart syndrome, and you can see the features of this. They're color coded, which makes it nice. But this teal structure is the first chamber of the right atrium, and then the right ventricle is shown here in purple, which is of normal size. But if you spin the model around, you can see this left ventricle, similar to the echoes that Dr. Turetsky showed. Left ventricle in this patient is quite small. And then the aorta is also quite small. And the way the physiology works is as Dr. Ronai highlighted, the pulmonary artery connects to the aorta and allows the right ventricle to do some of the work to send the blood to the body. And that's the fetal circulation. So as part of the surgical repair, what we really need to do is to rearrange the blood vessels so the right ventricle can easily pump the blood to the body. And remove the narrowing of the aorta that exists in almost all of these patients. And so if we then shift the model, we can see what it looks like after the Norwood operation or the stage 1 operation as the first step to palliate hypoplastic left heart syndrome. And you can see here what we do is connect the pulmonary valve to the aorta. And so now the ascending aorta has the native aorta shown here in red, and the pulmonary valve connected to it. And we've reconstructed the aorta to get rid of that narrowing and now make a normal sized aorta throughout. And we do that with a small patch that's used to do that. So what that does is that allows the right ventricle to send the blood to the entire body. And then the right ventricle also pumps the blood to the lungs after this operation. So what we typically do is connect another small tube between the right ventricle and the pulmonary artery shown here. That's called a sono conduit, or a right ventricle to pulmonary artery conduit. And if we look inside here, we can see this is the blood flows from the right ventricle to the pulmonary arteries to give blood to the lungs. If we look inside, then the blood goes through the right ventricle from the atria, both the left and the right atria, and gets pumped out from the right ventricle to the body. So that's the way the blood flows after the Norwood operation. And so, and then of course, as Dr. Ronai showed, there's subsequent operations, the Glenn and the Fontan, but this is the first step for patients with hypoplastic left heart syndrome. So I think it's wonderful to have the opportunity to share with families, at least in a big picture, what to expect in the surgery, and try to help sort of everybody be on the same page about the steps to get through the initial palliation, and then have our patients in as good of a position as possible for the next palliative steps.
Thank you so much. If anybody in our audience has any questions, please feel free to use the Q&A feature to submit questions. I do see a number of former families of ours on the attendee list, so thank you so much for joining. I think one of the questions that often comes up is, if you are born at your own institution and undergo your first surgery there, what are the options for coming to Boston for subsequent surgeries? Dr.
You want me to take that?
I do.
Yeah, so I mean, I think this is a common scenario that we face there. And I think both for patients with hypoplastic left heart syndrome that are going to be palliated down the single ventricle pathway, or patients with variations of that who may be able to get a series of procedures to recruit the size of the left ventricle, to have that involved in the circulation, either as the primary ventricle, as Dr. Turetsky was highlighting, that we've been able to accomplish with many of our patients who had the fetal intervention. Or now in recent years, we've even used the right ventricle as the ventricle to pump the blood to the body, and the left ventricle to handle some of the blood coming back from the body to pump that to the lungs to reduce the pressure in the veins of the lower body. And so we really intersect with patients all along their course. Many patients have their first surgery or even a couple surgeries at their local institution, and then reach out to us either for subsequent single ventricle palliation like the Fontan, or to potentially recruit a small ventricle to be part of the circulation. So I think, Dr. Turetsky's been part of all of these, phases as we've taken additional steps and have new options for patients. And I really think, there's a lot of promise in some of the new approaches we're taking. And I think, we're always excited to talk to families who may have the possibility to incorporate both ventricles into the circulation, which we think has terrific promise to reduce the risks and some of the long-term complications of Fontans as they get older.
Thank you. We have gotten a bunch of questions now, so thank you. What is the average day of the Norwood surgery in Boston after a prenatal diagnosis?
I think numerically it's about 4.
Yeah, day of life 4 usually.
Yeah, typically 3 to 7, but 4 or 5 is typical.
And then this one is for you, Wayne. What is the success rate for children with critical aortic stenosis after fetal intervention? Success as in avoiding HLHS and achieving a jackpot success.
Yes. No, that's a very important question. And it's a little more of a complicated answer, because if you look at early on in our experience, when we were still learning how to do the procedure, learning about patient selection, it was a much lower so-called jackpot success. More recently, as our team has got better at the procedure, patient selection is better, meaning there are some patients, like that first picture I showed you, where the heart is already too far advanced, and probably even doing the procedure would not result in success. And so the answer is it depends on the features going into the procedure. So we have a range of criteria. There are patients that we consider sort of okay candidates. There are ones that are really fantastic candidates. And so a little bit depends on the features going in. The way that we select our patients now, so based on all our experience, I'd say, in the last few years, I'd say we're up at around 70 to 80% of patients will end up with that kind of success. And remember, all of these patients, in order to be considered for this procedure, still have features of the natural history being hypoplastic left heart. So there are patients with aortic stenosis that we just continue to watch that have preserved function, preserved antegrade flow or forward flow around the arch. We would not do the procedure. We really wait for the features that tell us the patient is developing hypoplastic left heart. So it's a little more of a complicated answer, in the sense that there are patients that are not the sort of they're patients that probably have a lower rate of success, but we would do the procedure knowing that there are some innovative surgeries after birth as well, because all these patients are slightly different. So it's a very important question, but it is obviously a little more complicated of an answer.
What has changed and evolved in the surgical stages of hypoplastic left heart palliative surgeries compared to 30 years ago? Throw that to you, Dr. Hogenson.
Yeah, I think a number of things have evolved. Certainly the surgery used to be really successful in larger, more straightforward children, and we've evolved techniques to have similar outcomes in much smaller babies. And so now we've really refined techniques to do stage 1s on children less than 2.5 kilograms, which we've done routinely over the last several years. The patients with a very small ascending aorta, which is a common feature of patients with a subset of hypoplastic left heart syndrome, has long been a risk factor. And over the last 8 years or so, we've started to address that surgically by enlarging that during the operation if the aorta is really small, and have really eliminated that as a risk factor moving forward, which has been very important in some patients with really small ascending aortas. We're also as we have a really comprehensive single ventricle program that spans all of the phases, including a dedicated Fontaine clinic for older patients. We're really recognizing the impact of each of the surgical steps, both the technical aspect as well as the follow-up, and setting these patients up for really excellent long-term outcomes and being the best Fontaine you can possibly be. And so really dedicated to a lot of tiny refined aspects of the surgical reconstruction that early on have an impact later in the patient's course. And I guess the last thing that can highlight is for patients who have reduced flow to one lung as part of their pathway, rather than just accepting that and having them move forward as a higher risk patient, we've been able to demonstrate ability to recruit that lung and enlarge the pulmonary artery with additional flow in those patients. And that's really been a big benefit for some patients to be a better later single ventricle candidate. So there's a lot of things that we've done to improve that.
I think if there are no other questions, we can end our conversation on hypoplastic left heart fetal diagnosis and intervention. But thank you all for joining us. This has been a wonderful opportunity, and you know how to get a hold of us if you have any other questions. Thank you.